Remember when you are reading to continue to ask yourself how can this material be written into a question. Vocab, like most of radiology, the bulk of understanding the pathology is knowing the right words to use, plus, a big vocabulary makes you sound smart. Consolidation equals density that obscures underlying vessels. Ground glass opacity equals density that does not obscure underlying vessels. Secondary pulmonary lobule equals the basic unit of pulmonary structure and function. It is the smallest part of the lung that is surrounded by connective tissue. In the middle runs a terminal bronchiole with an accompanying artery. Around the periphery runs the vein and lymphatics. Anatomy of the secondary pulmonary lobule. Veins runs along the sides. Airway and artery run down the middle. Veins runs along the sides. Lymphatics run around the periphery. 334. Nodule vocabulary, random, paralymphatic, centrilobular. Random. Telling them apart can be done by first asking if they are but the pleura. If the answer is no, they are centrilobular. If the answer is yes, then ask do they follow a parabronchovascular pattern. Paralymphatic centrilobular. Pleural nodules. Subpleural and / plus paralymphatic parabronchovascular, ___________. No predominance random. No pleural nodules. ___. Centrilobular. If the answer is no, then they are random. If the answer is yes, then they are paralymphatic. Nodule pattern key DDX. Perilymphatic sarcoid, 90%, lymphangitic spread of Ca silicosis. Random miliary TB Mets fungal. Centrilobular infection RBILD hypersensitivity pneumonitis, if ground glass. 335. Patterns and pathology. Interlobular septa / thickening, reticular abnormality, that outlines the lobule's characteristic shape and size, about 2 cm. It's usually from pulmonary edema, usually symmetric and smooth, or lymphangitic spread of neoplasm, often asymmetric and nodular. Kerley B lines are the plain film equivalent. Honeycombing, cystic areas of lung destruction in a subpleural location. This is a hallmark of UIP. Paraseptal emphysema is a mimic, but the distinction is made by how many rows of bubbles. 1 row of bubbles equals paraseptal emphysema. 2-3 rows of bubbles equals honeycombing. Pathology time. Honeycombing, 2 examples. Idiopathic interstitial pneumonitis. These are not diseases, but instead lung reactions to lung injury. They occur in a variety of patterns and variable degrees of inflammation and fibrosis. The causes include idiopathic, collage vascular disease, medications, and inhalation. For practical purposes, the answer is either A, UIP, or B, not UIP. Not UIP will get better with steroids. UIP will not. UIP has a dismal prognosis, similar to lung cancer. Not UIP often does okay. The exam will likely not make it this simple, and will instead focus on buzzwords, patterns, and associations, which I will now discuss. 336. C9 UIP, usual interstitial pneumonia. This is the most common interstitial lung disease. When the cause is ictlocat, it is called IPF. On CXR, the lung volume is reduced, it's fibrosis. Reticuled pattern in the posterior costophrenic angle is supposedly the first finding on CXR. Buzzword / times include, apical to basal gradient, it's worse in the lobes, traction bronchiectasis, and honeycombing. Honeycombing is found 70% of the time, and people expect you to knee-jerk UIP when that term is uttered. Histologic buzzword equals heterogeneous. The histology was heterogeneous equals UIP. 2. It's important to know that basically any end-stage lung disease, be it from sarcoid, Ra, or esclerodema, or other collage and vascular DIAE, has a similar look once the DI. Cs has times rummed the lungs. Asterisk technically honeycomb ZS uncommon end stage sarcoid, but the rest of the lung looks jacked up. The prognosis is terrible, similar to lung cancer. UIP honeycombing, traction bronchiectasis, apical to basal gradient. 337. NSIP, specific interstitial pneumonia, less common than UIP. Even though the name infers that it's non-specific, it actually is a specific entity. Histologically it is homogeneous inflammation or fibrosis, UIP was heterogeneous. It is a common pattern in collage vascular disease, and drug reactions. It comes in 2 flavors, cellular or fibrotic. Ground glass alone equals cellular ground glass plus reticulation equals cellular or fibrotic reticulation plus traction bronchiectasis equals fibrotic NSIP honeycombing, uncommon and usually minimal in extent. The disease has a lower lobe, posterior, E_eripheral predomum C with pari of the immediate subpleural lung seen in up to 50% of cases. This finding of immediate subpleural sparing is said to be highly suggestive. Ground glass is the NSIP equivalent of honeycombing. NSIP, peripheral ground glass with subpleural sparing. / comma semicolon dot comma / dot exclamation point. LUIP.I./ backslash apical to basal gradient. Heterogeneous histology honeycombing traction bronchiectasis. 1J. _. Gradient is less obvious, but still more in lower lobes. L. Homogeneous L. Listology ground glass micronodules. Trivia, times NSJP is the most common interstitial lung disease I scleroderma. 338. RBILD and DIP, I'm going to discuss these two together because some people feel they are a spectrum. For sure they are both smoking-related diseases. RBILD apical centrilobular ground glass nodules DIP, more diffuse GGO, with patchy or subpleural distribution. RBILD, respiratory bronchiolitis plus symptoms equals RBILD. This tends to be more upper lobe predominant, note that DIP tends to be more lower lobe predominant. Localized centrilobular ground glass nodules. The pathology tends to involve the entire cross-section of lung. RBILD apical centrilobular ground glass nodules and smoking history. History. DIP, thought of as the end spectrum or for BILD. Peripheral lower lobe predominant ground glass, with small cystic spaces. 339. Sarcoid, this is a multisystem disease that creates non-casseting granulomas. The classic age is between 20 to 40. Along those lines, if the header to the question describes an African American female in her 20s 30s, the answer is probably sarcoid. The lungs are by far the most common organ affected, 90%. MISC trivia to know, elevated angiotensin converting enzyme, ACE, hypercalcemia. Mediastinal lymph nodes are seen in 60 to 90% of times, classically in a 1-2-3 pattern of bilateral hilar and right paratrichal. They have perilymphatic nodules, with an upper lobe predominance. Late changes include upper lobe fibrosis and traction bronchiectasis. Honeycombing is rare. Aspergillomas are common in the cavities of patients with end-stage sarcoid. 1-2-3 sign, bilateral high forward/er and right paratrichal lambda sign, same as 1-2-3. But on Gaulium scan CT galaxy sign, upper lobe masses, conglomerate of nodules, with satellite nodules. CXR can be used to stage sarcoid. Stage 0 equals nona. Stage I equals hilar I mediastinal nodes only. Stage 2 equals nodes plus parenchyma disease. Stage 3 equals parenchymal disease. Stage 4 equals end stage, fibrosis. 340. CHFC. Common organ affected, 90%. MISC trivia to know, elevated angiotensin converting enzyme, ACE, hypercalcemia. Ages between 20 to 40. Along those lines. (340). CHF is obviously not an ILD. However, it can sorta look like one on chest X-ray, so I opted to lump it in here. Congestive heart failure occurs because of cardiac failure, fluid overload, high resistance in the circulation, or some combination of the three. There are 3 phases of CHF, and these lend themselves to testable trivia. Stages of CHF 1. _J. J stage 1 redistribution. Wedge pressure 13 to 18. 1 cephalization of vessels, big I. I heart, big vascular pedicle IL times I times 1 I stage. Stage 2 interstitial I wedge pressure 18 to L ___________. I stage 3 alveolar edema J wedge pressure 25 J airs ace fluffy opacity plural J LIIIF fusion times __________ dash I central vessels I. Dash I central vessels I. L ___________. I stage 3 alveolar edema J wedge pressure 25 J airs ace fluffy opacity plural J LIIIF fusion times _____________________ 1 dash times 1. Right heart failure. This is less common than left heart failure, which ironically is the most common cause. Left heart failure causes pulmonary venous HTN, which causes pulmonary artery HTN, which causes right heart failure. Some other less common causes of right heart failure include chronic PA and right-sided valve issues, tricuspid regurg. The imaging features of right heart failure include dilation of the azygos vein, dilation of the right atrium, dilation of the SVC, ascites, big liver, and contrast reflux into the hepatic veins on CTPA. 341. Section 9 transplant. Lung transplants are done for end-stage pulmonary disease, fibrosis, COPD, etc. The complications lend themselves easily to multiple-choice test questions, and are therefore high yield. The best way to think about the complications is based on time. Immediate complications. Donor recipient _T_Is mismatch I mismatch up to 25% is okay. You can have I compressed lung, by the hyperexpanded. I hyperacute rejection. I emphysematous lung. Imaging is usually I at hectors 1s. Secondary to HLA and ABO antigens. J rapid and often fatal. Imaging shows I massive homogeneous infiltration. It's early complications, 24 hours minus 1 week. Reperfusion injury. LE I persistent pneumothorax. J peaks at day 4 as a non-cardiogenic edema I related to ischemia reperfusion. Typically I improves by day 7. I defined as a continuous leak for Emery T71. I days. Altgarmedi.et complica N 8 days, 2 months, acute rejection L ground glass opacities and intralobular. I septal thickening. No ground glass equals no I. L rejection. Improves with steroids. I F BRN Heil, Stomoti omplications ____IO, Eastern I, CA _N I. CMV infection. Chronic rejection. Late complications --, 2 to 4 months. I the most common opportunistic II infection. Ground glass, tree in bud. Before 2 weeks. Later complications, 4 months. Rare. I bronchiolitis obliterans, affects 50% at 5 years. Bronchiectasis, bronchial wall I thickening, air trapping. 1 cryptogenic organizing pneumonia I occurs with chronic rejection, but more L. Commonly with acute rejection. Response. 1 I to steroids. D _____________________ J typically seen within the first year. EBV in upper lobe fibrosis. L90%. I-4. Associated with chronic rejection times M times I. BRN Heil, Stomoti omplications ______IO, Eastern I, CA _ Chronic rejection I bronchiolitis obliterans syndrome. This is the major late complication that affects at least half of the transplants at 5 years, most commonly at 6 months. The term bronchiolitis obliterans is often used interchangeably with chronic rejection. The findings on CT include bronchiectasis, bronchial wall thickening, air trapping, and interlobular septal thickening. Just think air trapping on expiration seen at or after 6 months equals chronic rejection. Recurrence of primary disease after transplant. For the purpose of multiple choice tests, know that sarcoidosis is the most common recurrent primary disease, around 35%. Lots of other things can recur. Lung cancer after transplant, just remember that native lung is still diseased, and can get cancer. The highest rate is with pulmonary fibrosis, and the most common risk factor is heavy tobacco use. 343. Section 10 alveoli-AR. Pulmonary alveolar proteinosis. PAP for the purpose of multiple choice. This is an AND mini, always shown as crazy paving lung, interlobular septal thickening, with ground glass. This can be primary, 90%, or secondary, 10%. The secondary causes worth knowing are cancer or inhalation, silicoproteinosis. Trivia worth knowing, they are at increased risk of nocardia infections, and can be nocardia brain abscess. Smoking is strongly associated with the disease. When seen in children, presenting before age 1, there is a known association with a lymphoplasia. Can progress to pulmonary fibrosis, 30%. Treatment is bronchoalveolar lavage. Crazy paving, interlobular septal thickening and ground glass. This isn't always PAP, in fact in real life that it is usually not PAP. There is a differential that includes common things like edema, hemorrhage, back, acute interstitial pneumonia. Just know that for the purpose of multiple choice test the answer is almost always PAP. 344. Lipoid pneumonia. There are actually two types, endogenous and exogenous. Exogenous, a certain percentage of elderly people become absolutely obsessed with their bowel movements. If you did family medicine addressing this psychopathology would steal a certain amount of hours out of your life per week. Lipoid pneumonia is seen in old people who like to drink /aspirate mineral oil, as a laxative. It can also be seen with the aspiration of vegetable oil or other animal oils. The look on plain film is an area of lung acidification that is chronic or slowly increases with time. The look on CT is a dead giveaway, and the most likely way this will be shown is with low attenuation eye fat density in the consolidation. Having said that, this is also in the crazy paving differential. Acute exogenous lipoid pneumonia. This is seen as children who accidentally poison themselves with hydrocarbons, or idiots trying to perform fire eating or flame blowing. Endogenous. This is actually more common than the exogenous type, and results times from post-obstructive processes, cancer, causing the building up of lipid-laden macrophages. Lipoid pneumonia, fat density in the consolidation. Game immunship, why are you sure 11 wing me the Lu 11G01111111 wind W? Obviously pulmonary pathology is best shown on a lung window. So anytime the test writer is showing you a pulmonary pathology on a non-lung window, that should cue you to think about some different things. I is the findings in the mediastinum or ribs. 2. If it's clearly a lung findings, then what window arc they using? Soft tissue window is classically used to show fat in a lesion, thin hematoma, or lipoid pneumonia. Bone window might be used to show a diffuse process such as pulmonary microlithiasis. 345. Organizing pneumonia, cryptogenic when cause not known COP. This used to be called BOOP, which was a lot more fun to say. There are lots of different causes: idiopathic, infection, drugs, amiodarone, collagen vascular disease, fumes etc. These guys respond well to steroids, and have an excellent prognosis. Patchy airspace consolidation or GGO, 90%, in a peripheral or peribronchial distribution. Opacities tend to be irregular in shape. Findings of fibrosis are typically absent. Reverse halo, atoll, sign is the classic sign, consolidation around a ground glass center. Cryptogenic organizing pneumonia, reverse halo sign. Chronic eosinophilic pneumonia, can be idiopathic or associated with a known antigen. Peripheral eosinophilia, blood test, is usually present. An asthma history is found in about 50% of cases. It looks exactly like COP. When you say COP you should say this one too, some people think it's the same disease as COP. CT findings, peripheral GGO or consolidation. Upper lobes tend to be favored. 346. Hypersensitivity pneumonitis, this is actually common. It's caused by inhaled organic antigens. It has acute, subacute, and chronic stages. Most of the time it's imaged in the subacute stage. Subacute, patchy ground glass opacities. Ill-defined centrilobular ground glass nodules, 80%. Often has mosaic perfusion, and air trapping. Chronic, looks like UJP plus air trapping. You are gonna have traction bronchiectasis and air trapping. A buzzword is head cheese because it's a mix of everything: ground glass, consolidation, air trapping, and normal lung. Halo signs. Reverse halo, atoll, central ground glass with rim of consolidation. DDX, COP, classic, fungal pneumonia TB Wegener's, pulmonary infarct. Halo nodule with ground glass around it represents hemorrhage eye invasion into surrounding tissues. DDX, invasive aspergillosis, classic, other fungus, hemorrhagic Metz Wegener's. 347. Section 11 Airways. Trachea. The basic anatomy of the trachea is a bunch of anterior horseshoes of cartilage, with a posterior floppy membrane. This membrane can bow inward on expiratory CT, and this is normal. The transverse diameter should be no more than 2.5 centimeters, same as the transverse diameter of an adjacent vertebral body. Times. Trickle disease game plan, 3 big questions to ask yourself. 1. Does it involve the posterior membrane? 2. Is it focal or diffuse? And 3. Is there calcification? Relapsing polychondritis, spare the posterior membrane. Diffuse thickening of the trachea. No calcifications. Characterized by recurrent episodes of cartilage inflammation and recurrent pneumonia. Post-intubation stenosis, focal subglottic circumferential stenosis, with an hourglass configuration. Wegener's, circumferential thickening, which can be focal or long segment. No calcifications. Subglottic involvement is common. Tracheobronchopathia osteochondroplastica, TBO, spares the posterior membrane. You have development of cartilaginous and osseous nodules within the submucosa of the tracheal and bronchial walls. Tracheobronchopathia osteochondroplastica, TBO, spares posterior membrane, arrow. Amyloidosis, irregular focal or short segment thickening, which can involve the posterior membrane. Calcifications are common. 348. Spares the posterior membrane - does not spare the posterior membrane. Relapsing recurrent episodes of polychondritis, cartilage inflammation, ears, nose, joints, laryngeal and thyroid. Amyloid often confined low the trachea and main bronchi. Calcifications are common. Tracheobronchopathia osteochondroplastica, TBO. Cartilage. Recurrent pneumonia is the most common cause of death. Development of Wegener's cartilaginous and osseous nodules. Typically occurs in men older than 50. Saber sheath trachea, defined as a coronal diameter of less than 2/3 the sagittal diameter. I say saber sheath trachea, you say COPD. Trivia: the main bronchi will be normal in size. The tracheal wall will be normal in thickness. See anchor plus, subglottic trachea is the most common location. Saber sheath trachea. Tracheal tumors of the trachea are not common in the real world. Tracheal tumors. 1J1 times most common. Associated with smoking, often multifocal squamous celli, times times. 349. Cystic fibrosis, the sodium pump doesn't work and they end up with thick secretions and poor pulmonary clearance. The real damage is done by recurrent infections. Things to know: bronchiectasis begins as cylindrical and progresses to varicoid. It has an apical predominance, lower lobes are less affected, hyperinflation, pulmonary arterial hypertension, mucus plugging, finger in glove. Primary ciliary dyskinesia, those little hairs in your lungs that clear secretions don't work. You end up with bilateral lower lobe cartilage bronchiectasis. Remember that CF is mainly upper lobe. Other things these syndrome kids get is chronic sinusitis, prominent from an early age, and impaired primary ciliary fertility. Sperm can't swim, girls get ectopics. They have chronic mastoid DS_sicky1xia and few times DD times H times 1 times TH111 Tyson versus ES10. S10NS, and conjunctivium gossis commonosity ear nerve hair. Things are fucked up too. An important testable fact is that only 50% of the primary ciliary dyskinesia patients have cartilaginous syndrome. CF primary ciliary dyschioesia abnormal mucus, cilia cannot move it normal mucus, cilia don't work normal sperm, absent vas deferens abnormal SPCNN, they can T-swim, nonal vas deferens upper lobe bronchiectasis lower lobe bronchiectasis. Williams-Campbell syndrome, huge zebra that is manifests as congenital cystic bronchiectasis from a deficiency of cartilage in the 4th to 6th order bronchi. Monia-Kuhn, tracheobronchomegaly, there is a massive dilatation of the trachea, 3 centimeters. It's not well understood, and really the only thing that does this. Mounla-Kuhn big fucking trachea. 350. Small airways disease. Bronchiolitis, this is an inflammation of the small airways. It can be infectious, like the viral patterns you see in kids, or inflammatory like RBILD in smokers, or asthma in kids. Air trapping: when you see areas of lung that are more lucent than others, you are likely dealing with air trapping. Technically, air trapping can only be called on an expiration study, as hypoperfusion in the setting of pulmonary arterial hypertension can look similar. Having said that, for the purpose of multiple choice test taking, I want you to think: 1. bronchiolitis obliterans in the setting of a lung transplant, or 2. Small airway disease, asthma I bronchiolitis. Air trapping, the poster boy for small airway disease. Tree in bud, this isn't a specific finding that can make you think small airway disease. It's caused by dilation and impaction of the centrilobular airways. Because the centrilobular airways are centered 5 to 1 from the pleural surface, that's where they will be. It's usually associated with centrilobular nodules. Follicular bronchiolitis, this is an inflammatory process seen in rheumatoid arthritis or Sjogren's. It's not well understood and related to some lymphoid hyperplasia. It looks like centrilobular ground glass nodules with scattered areas of bronchial dilation. Constrictive bronchiolitis, this is another inflammatory process that can be seen secondary to viral illness, transplant patients, drug reactions, or inhalation injury. It occurs secondary to mononuclear cells which form granulation tissue and plug the airway. You see air trapping on expiratory imaging. This is supposedly the cause of Swyer-James hyperlucent lung. I small airway disease underscore 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 I. J inhaling dust I other misc garbage. Centrilobular. Subacute hypersens 1 tiv 1 ti pneumomed 1s1 ground glass nodule. Aspiration pneumonia, stroked out old people and drunks love to aspirate. The testable trivia is to know the typical location of aspiration, posterior segment of upper lobes and superior segment of lower lobes if supine when aspirating, bilateral basal lower lobes in upright aspiration. May favor the right side, just like an ET tube. The most common complication is infection which can manifest as an empyema, which can then get a bronchopleural fistula. Aspiration patterns, depends on what you aspirated. Aspiration of gastric acid Mendelssohn's I syndrome I gives you an airspace opacity. If massive I can look like pulmonary edema T-1 aspiration of water or neutralized gastric I fleeting opacity that resolves in hours. Contents. 1. I. Aspiration of bugs, often mouth bugs. J gives you a real pneumonia, can get para 1 pneumonic effusion, empyema, or even. Times dash, bro underscore NC underscore H underscore O underscore plural fistula. Underscore 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 I. L. 352. Section 12. Systemic disease. Collagene vascular disease. Interstitial lung diseases are common in patients with collagene vascular diseases. I've tried to hit the high points of testable trivia. Collagene vascular disease pulmonary manifestations. Lupus more plural effusion S and I fibrosis is uncommon. Can J pericardile effusions than I get a shrinking lung? IL with other connective tissue I. Dash, times, times underscore 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 J underscore. Times dash. Times dash times. Times 1. OSing spawn dyli. SOBBRBuitus : equals disease underscore 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 underscore. Kaplan syndrome equals rheumatoid arthritis plus upper lobe predominant lung nodules. These nodules can cavitate, and there may also be a pleural effusion. Shrinking lung. This is a progressive loss of lung volume in both lungs seen in patients with lupus, shrinking L lung for SLE. The etiology is either diaphragm dysfunction or pleuritic chest pain. Trivia: most common manifestation of SLE in chest equals pleuritis with / without pleural effusion. Hepatopulmonary syndrome. This is seen in liver patients with the classic history of shortness of breath when sitting up. The opposite of what you think about with a CHF patient. The reason it happens is that they develop distal vascular dilation in the lung bases, subpleural telangiectasia, with dilated subpleural vessels that don't taper and instead extend to the pleural surface. When the dude sits up, these things engorge and shunt blood, making him / her short of breath. A TCMA scan will show shunting with tracer in the brain, outside the lungs. They have to either tell you the patient is cirrhotic, show you a cirrhotic liver, or give you that classic history if they want you to get this. 353. Wegener granulomatosis. The classic triad is upper tract, lung, and kidneys, although this triad is actually rare. The lungs are actually the most common organ involved, 95%. There is a highly variable look. The most common presentation is also probably the most likely to be tested, nodules with cavitation. The nodules tend to be random in distribution with about half of them cavitating. They can also show you ground glass changes which may represent hemorrhage. This is now called granulomatosis with polyangioitis because Wegener was a Nazi. Goodpasture syndrome, another autoimmune pulmonary renal syndrome. It favors young men. It's a supina-specific look with bilateral coalescent airspace opacities that look a lot like edema, but are hemorrhage. They resolve quickly, within 2 weeks. If they are having recurrent bleeding episodes, then they can get fibrosis. Pulmonary hemosiderosis can occur from recurrent episodes of bleeding as well, with iron deposition manifesting as small ill-defined nodules. 354. Section 13. Pleura, diaphragm, chest wall. Plaque. If they show you a pleural plaque, they probably want you to say asbestos-related disease. Remember, the plaque doesn't show up for like 20 to 30 years after exposure. Remember that the pleural plaque of asbestosis typically spares the costophrenic angles. Pleural calcifications, other than asbestos. Old hemothorax, old infection, TB, extraskeletal osteosarcoma. Mesothelioma, the most common cancer of the pleura. About 80% of them have had asbestos exposure, and development is not dose-dependent. The lag time is around 30 to 40 years from exposure. The buzzword pleural rind is worth knowing. The tendency is for direct invasion. Extension into the fissure is highly suggestive. Fibrous tumors of the pleura, this is usually a solitary tumor arising from the visceral pleura. The key is to know that they are not associated with asbestos, smoking, or other environmental pollutants. They can get very large, and be a source of chest pain, although 50% are incidentally found. The second high-yield testable fact is the association with hypoglycemia and hypertrophic osteoarthropathy. Metastases, here is the high-yield trivia on this. As a general rule, the subtype of adenocarcinoma is the most likely to met to the pleura. Lung cancer is the most common and primary, with breast and lymphoma at second and road. Remember that a pleural effusion is the most common manifestation of mets to the pleura. Lipoma, this is the most common and benign soft tissue tumor of the pleura. The patients sometimes feel the urge to cough. They will not cause rib erosion. They never turn into a sarcoma. The differential consideration is extrapleural fat, but it is usually bilateral and symmetric. 355. Effusion, some random factoids on pleural effusions that could be potentially testable. There has to be around L75 cc of fluid to be seen on the frontal view, around 75 cc can be seen on the lateral. Remember that medicine docs group these into transudate and exudate based on protein concentrations, Light's criteria. You are going to get elastic eye compressive atelectasis of the adjacent lung. Subpulmonic effusion, a pleural effusion can accumulate between the lung base and the diaphragm. These are more common on the right, with ski slopping or lateralization of the diaphragmatic peak. A lateral decubitus will sort it out in the real world. Empyema, basically this is an infected pleural effusion. It can occur with a simple pneumonia but is seen more in people with AIDS. Usually these are more asymmetric than a normal pleural effusion. Other features include enhancement of the pleura, obvious septations, or gas. F*-empyema vs pulmonary abscess. Empyema pulmonary abscess. Lentiform round. Split pleural sign, thickening and separation claw sign, acute angle with pleura, of the visceral and parietal pleura. Treated with chest tube, not treated with chest tube, risk of bronchopleural fistula. Empyema necessitans, this is the fancy Latin word for when the empyema eats through the chest. Chest wall and into the soft tissues. It's classically seen with TB, 70%, with the second most common cause being actinonitis. 356. Diaphragmatic hernia, these can be acquired via trauma, or congenital. The congenital ones are most common in the back left, Boak-Dalek, with anterior small and right being less Karanen, more Gigni. The traumatic ones are also more common on the left, liver is a buffer. Paralysis, this is a high-yield topic because you can use fluoro to help make the diagnosis. Obviously the dinosaurs that write these tests love to ask about fluoro, since that was the only thing they did in residency. Diaphragmatic paralysis is actually idiopathic 70% of the time, although when you see it on multiple choice tests they want you to think about phrenic nerve compression from a lung cancer. Normally the right diaphragm is higher, so if you see an elevated left diaphragm, this should be a consideration. On a fluoroscopic sniff test you are looking for paradoxical movement, going up on inspiration, instead of down. 357. Section 14. Mediastinal masses. Superior mediastinal masses. These are often lumped into anterior mediastinal masses, as extension often occurs upward. Superior sulcus tumor, notice I didn't call it a pancoast tumor. To be a pancoast tumor you need to have pancoast syndrome, which is shoulder pain, C8T2 radicular pain, and Homer syndrome. The superior sulcus tumor can cause these but doesn't have to. The most common tumor to do this is a squamous cell lung cancer, or bronchogenic adenocarcinoma, depending on what you read. Non-small cell tumors may be a safer way to say it. The cladotoic question, when is the S11 perior sulcus, pancoast, tumor unresectable? L brachia /plexus involvement above TL, C8 or higher, 2. Diaphragm paralysis, I FIRS involvement of CJ./5, 3. Greater than 50% vertebra /HODI 4. Distal nodes or METs, etc. Next step. MI is often used for staging, because you need to exclude involvement of the brachial plexus. If given the choice between CT or MI for staging I would say go MI. 358. Anterior mediastinal masses. Thymus. The thymus can do a bunch of sneaky things. It can rebound from stress or chemotherapy and look huge. It can get cysts, cancer, carcinoid, etc. A rebound, discussed in detail in the PEDS chapter. After stress or chemotherapy the thing can blow up 1.5 times the normal size and simulate a mass. Can be hot on PET. Othymic cyst, can be congenital or acquired. Acquired is classic after thoracotomy, chemotherapy, or HIV. They can be unijocular or multilocular. T2 bright is gonna seal the deal for you. Rebound vs residual lymphoma. 1. PET might help, both are hot, but lymphoma is hotter. 2. MI thymic rebound should drop out on in out of phase imaging, it has fat in it. Lymphoma will not drop out. Othymoma, so this is kind of a spectrum ranging from non-invasive thymoma, to invasive thymoma, to thymic carcinoma. Calcification makes you think it's more aggressive. The thymic carcinomas tend to eat up the mediastinal fat and adjacent structures. The average age is around 50, and they are rare under 20. These guys can drop met into the pleural and retroperitoneum, so you have to image the abdomen. High-yield trivia, thymoma associations, myasthenia gravis, pure red cell aplasia, hypogammaglobulinemia. Othymolipoma, I'll only mention this zebra because it has a characteristic look. It's got a bunch of fat in it. Think fatty mass with interspersed soft tissue. Germ cell tumor almost always tritoma, 75%. Mediastinal tritoma. This is the most common extragonadal germ cell tumor. They occur in kids, below age 1, and adults, 20s 30s. They are benign, but carry a small malignant transformation risk. Mature subtypes are equal in men and women, but immature subtypes are exclusively seen in men, which should be easy to remember. There is an association with mature tritomas and Klinefelter syndrome. The imaging features include a cystic appearance, 90%, and fat. They can have calcifications including teeth, which is a dead giveaway. Thyroid cancer and goiter are described in detail in the endocrine chapter. Lymphoma, this is discussed in detail in the cancer section of this chapter. Pericardial cyst, this is uncommon and benign. The classic location is the right anterior cardiophrenic angle. This classic location is the most likely question. 359. Middle mediastinal masses. Fibrosing mediastinitis, this is a proliferation of fibrous tissue that occurs within the mediastinum. It's classically caused by histoplasmosis, but the most common cause is actually idiopathic. Other causes include TB, radiation, and sarcoid. It's a soft tissue mass with calcifications that infiltrates the normal fat planes. It has been known to cause superior vena cava syndrome. It's associated with retroperitoneal fibrosis when idiopathic. Bronchogenic cyst. These congenital lesions are usually within the mediastinum, most commonly found in the subcarinal space, or less commonly intraparenchymal. For the purpose of the exam, they are going to be in the subcarinal region, causing obliteration of the azygoesophageal line on ACXR, and being waterish density on CT. Lymphadenopathy, could be METs, could be infection, could be reactive. Mediastinal lipomatosis, excess unencapsulated fat seen in patients with iatrogenic steroid use, Cushing's, and just plain old obesity. Posterior mediastinal masses. Neurogenic, the most common posterior mediastinal mass is one of neurogenic origin. This includes schwannomas, neurofibroma, and malignant peripheral nerve sheath tumors. Bone marrow, extramedullary hematopoiesis, EMH, is a response to failure of the bone marrow to respond to EPO. Classic conditions include CML, polycythemia vera, myelofibrosis, sickle cell, and thalassemia. 360. Section 1.5. Pulmonary arteries. Pulmonary embolism, this is a significant cause of mortality in hospitalized patients. The gold standard is catheter angiography, although this is invasive and carries risks. As a result, tests like the D-dimer, which has an almost 100% negative predictive value, and the DVT lower extremity ultrasound were developed. Now, the CTPA as the primary tool. Historical high-yield signs of PA on a CXR_______L. I equals R dot dash 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 1. I Hampton's hump J peripheral wedge-shaped opacity times I. 1 pleural effusion, obviously not specific, but seen in 30% of PES. Differentiating acute vs chronic PA is a high-yield tool. Acute vs chronic PA, acute chronic central peripheral venous dilation, shrunken veins with collateral vessels. Perivenous soft tissue edema, calcifications within the thrombi and within the venous walls. Pulmonary infarct mimics. A pulmonary infarct is a wedge-shaped opacity that is going to melt, resolve slowly, and sometimes can cavitate. Obviously, a cavitary lesion throws up lots of flags and makes people say TB or cancer. When it's an opacity in the lung and the patient doesn't have a fever, sometimes people think cancer. Plenty of pulmonary infarcts have been biopsied. 361. Pulmonary artery aneurysm /pseudoaneurysm _ think about 3 things for multiple choice. 1. Iatrogenic from Swan-Ganz catheter * most common. 2. Behçet's. 3. Chronic PA. When they want to lead towards Swan-Ganz, they may say something like patient in the ICU. The buzzwords for Behçet's are Turkish descent and mouth and genital ulcers. Hughes-Stovin syndrome. This is a zebra cause of pulmonary artery aneurysm that is similar, and may be the same thing, as Behçet's. It is characterized by recurrent thrombophlebitis and pulmonary artery aneurysm formation and rupture. Rasmussen aneurysm. This has a cool name, which instantly makes it high yield for testing. This is a pulmonary artery pseudoaneurysm secondary to pulmonary TB. It usually involves the upper lobes in the setting of reactivation TB. Tetralogy of Fallot repair gone south, so another possible testable scenario is the patch aneurysm, from the AVO repair. Pulmonary hypertension. Pulmonary arterial pressures over 25 are going to meet the diagnosis. I prefer to use the outdated primary and secondary way of thinking about this. Primary, the idiopathic type, is very uncommon, seen in a small group of young women in their 20s. Secondary, this is by far the majority, and there are a few causes you need to know. Chronic PA, right heart failure /strain, lung parenchymal problems. This would include emphysema, and various causes of fibrosis. COPDs with a pulmonary artery bigger than the aorta, a /par ratio, have increased mortality, says the NEJM. Imaging signs of pulmonary HTN, the big pulmonary artery, 29 mm, or larger than the aorta. Mural calcifications of central pulmonary arteries, seen in Eisenmenger phenomenon. Right ventricular dilation and hypertrophy. Centrilobular ground glass nodules. Pulmonary veno-occlusive disease, uncommon variant of primary pulmonary hypertension, that affects the post-capillary pulmonary vasculature. For gamesmanship par and normal wedge, you should think this. The normal wedge pressure differentiates it from other post-capillary causes, such as left atrial myxoma, mitral stenosis, and pulmonary vein stenosis. 362. Section 16 Trauma. Diaphragmatic injury. There is a lot of testable trivia regarding diaphragmatic injury, and therefore it is probably the most high-yield subject with regard to trauma. Things to know: left side is involved 3 times more than the right, liver is a buffer, most ruptures are radial, longer than 1 cm, and occur in the posterior lateral portion. Collar sign. This is sometimes called the hourglass sign, is a waist-like appearance of the herniated organ through the injured diaphragm-dependent viscera sign. This is an absence of interposition of the lungs between the chest wall and upper abdominal organs, liver on right, stomach on left. Tracheobronchial injury, airway injury, is actually pretty uncommon. When it does occur, it's usually within 2 cm of the carina. Injury close to the carina is going to cause a pneumomediastinum rather than a pneumothorax, that is a testable fact. When you get a tracheal laceration, it most commonly occurs at the junction of the cartilaginous and membranous portions of the trachea. Macklin effect. This is probably the most common cause of pneumomediastinum in trauma patients, and most people haven't heard of it. The idea is that you get alveolar rupture from blunt trauma, and the air dissects along bronchovascular sheaths into the mediastinum. Boer-Haave syndrome, you probably remember this from step 1. The physical exam buzzword was Hammond's crunch. Basically you have a ruptured esophageal wall from vomiting, resulting in pneumomediastinomyomediastinitis. Flail chest, this is 3 or more segmental, more than 1 fracture in a rib, fractures, or more than 5 adjacent rib fractures. The physical exam buzzword is paradoxical motion with breathing. Pneumothorax, obviously you don't want to miss the tension pneumothorax. The thing they could ask is inversion or flattening of the ipsilateral diaphragm. Malpositioned chest tubes, sometimes the ED will ram them into the parenchyma. This is more likely to occur in the setting of background lung disease or pleural adhesions. You'll see blood around the tube. Bronchopleural fistula may occur as a sequela. The placement of a tube in a fissure is sorta controversially bad, might be okay. 363. Hemothorax, if you see pleural fluid in the setting of trauma, it's probably blood. The only way I can see them asking this is a density question. A good density would be 35 to 70 HU. Extrapleural hematoma, this is a little tricky, and they could show you a picture of it. If you have an injury to the chest wall that damages the parietal pleura, then you get a hemothorax. If you have an injury to the chest wall, but your parietal pleural is still intact, you get an extrapleural hematoma. The classic history is persistent fluid collection after pleural drain /tube placement. The buzzword I sign is displaced extrapleural fat. There is a paper out there that suggests a biconvex appearance is more likely arterial and should be watched for rapid expansion. This may be practically useful, but is unlikely to be asked. Just know the classic history, and displaced extrapleural fat sign. Extrapleural hematoma arrows on the displaced fat. Pulmonary contusion, this is the most common lung injury from blunt trauma. Basically you are dealing with alveolar hemorrhage without alveolar disruption. The typical look is non-segmental ill-defined areas of consolidation with subpleural sparing. Contusion should appear within 6 hours, and disappear within 72 hours. If it lasts longer, it's probably aspiration, pneumonia, or a laceration. Pulmonary laceration, so a tear in the lung will end up looking like a pneumatocele. If they show you one, it will probably have a gas fluid, blood, level in it. These things can be masked by surrounding hemorrhage early on. The major difference between contusion and laceration is that a laceration resolves much more slowly and can even produce a nodule or a mass that persists for months. 364. Aorta. The aorta is injured most commonly at the aortic isthmus, some sources say 90%. The second and third most common locations are the root and at the diaphragm. Some people say the root is actually the most common, but most of these people die prior to making it to the hospital. This is a minority opinion. If asked what is the most common site of traumatic aortic injury, the answer is isthmus. It's usually obvious on a candy cane CTA. The main mimic would be adductus bump, which is a normal variant. The way to tell, if it isn't obvious, is the presence of secondary signs of trauma, mediastinal hematoma. Blunt cardiac injury. If you have hemipericardium in the setting of trauma, you can suggest this and have the ED correlate with cardiac enzymes and EKG findings. Fat embolization syndrome. This is seen in the setting of a long bone fracture or ultramedullary rod placement. You get fat embolized to the lungs, brain and skin, clinical triad of rash, altered mental status, and shortness of breath. The timing is 1 to 2 days after the femur fracture. The lungs will have a ground glass appearance that makes you think pulmonary edema. You will not see a filling defect like a conventional PE. If they don't die, it gets better in 1 to 3 weeks. Barotrauma. Positive pressure ventilation can cause alveolar injury, with air dissecting into the mediastinum, causing pneumomediastinum and pneumothorax. Patients with acute lung injury or COPD have a high risk of barotrauma from positive pressure ventilation. Lungs with pulmonary fibrosis are actually protected because they don't stretch. 365. Section 17. Lines and devices. Central lines. The main way to ask questions about central lines is to show them being malpositioned and asking you where they are. An abrupt bend at the tip of the catheter near the cavo-atrial junction should make you think azygos. If it's on the left side of the heart, it's either 1. Arterial or B. In a duplicated SVC. This is a sneaky trick, related to central lines. They can show you the pseudo-lesion I hot quadrate sign, seen with SVC syndrome, and then show you ACXR with a central venous catheter. The idea is that central lines are a risk factor for SVC occlusion. Hot quadrate sign from SVC obstruction. Endotracheal tube, ETT, positioning. The tip of the ETT should be about 5 cm from the carina, halfway between the clavicles and the carina. The tip will go down with the chin tucked, and up with the chin up. The hose goes where the nose goes. Intubation of the right main stem is the most common goof. Because of the more shallow angle, this can lead to left lung collapse. You can sometimes purposefully intubate one lung if you have massive pulmonary hemorrhage, lung biopsy gone bad, to protect the good lung. 366. Intra-aortic balloon pump, IABP. This is used in cardiogenic shock to help with diastolic augmentation, essentially providing some back pressure so the vessels of the great arch, including the coronaries, enjoy improved perfusion. For the purpose of multiple choice tests you can ask 3 things. 1. What is the function? Decrease LV afterload, and increased myocardial perfusion. 2. What is the correct location? The balloon should be located in the proximal descending aorta, just below the origin of the left subclavian artery. Balloon terminates just above the splanchnic vessels. 3. Complications. Dissection during insertion, obstruction of the left subclavian from malpositioning. IABP, position. ACR appropriateness criteria, this is high-yield trivia. First line for suspected metastatic disease equals CXI. Recommendation for patients on mechanical ventilation equals daily CXI. First line for chest pain and high suspicion for aortic dissection equals CXI. L times dash times dash times underscore J. 367. Blank for notes. 368. Chapter 8. Cardiac Prometheus Lionheart, MD. Highest yield tip. Cardiac imaging can be very difficult, between all the funky congenital heart stuff and cardiac MI that a lot of community programs don't even do. If I was from a smaller program that doesn't do much cardiac MI, I would definitely concentrate on MR cases and how the sequences are obtained. If I felt good on cardiac MR, I would double down on all the congenital stuff including the surgeries, both past and present. 369. Section underscore chambers. Right atrium, defined by the IVC. The crista terminalis is a frequently tested normal structure. It's not a clot or a tunnel. It is a muscular ridge that runs from the entrance of the superior to that of the inferior vena cava. Another normal anatomic structure that is frequently shown, usually on IVC gram, is the IVC valve or Eustachian valve. It looks like a little flap in the IVC as it hooks up to the atrium. When the tissue of this valve has a more trabeculated appearance, it is called a Chiari network. Coronary sinus, the main draining vein of the myocardium. It runs in the AV groove on the posterior surface of the heart and enters the right atrium near the tricuspid valve. Right ventricle, defined by the moderator band, has several characteristics that are useful for distinguishing it, and make good test questions. Crista terminalis not a clot. The tricuspid papillary muscles insert on the septum, not the case with the mitral valve. There is no fibrous connection between the AV valve and outflow tract. The pulmonary valve has 3 cusps, and is separated from the tricuspid valve by a thick muscle known as the crista supraventricularis. This differs from the left ventricular outflow tract, where the mitral and aortic valves lie side by side. Coronary sinus moderator band also not a clot. The left-sided valves binge together. The right-sided valves have an infundibulum between them. 370. Left atrium, the most posterior chamber. When you think about multiple choice questions regarding the left atrium, think about the various signs of enlargement. Double density, direct sign superimposed second contour on the right heart, from enlargement of the right side of the left atrium, splaying of the carina. Indirect sign angle over 90 degrees suggests enlargement walking man sign. Indirect sign posterior displacement of the left main stem bronchus on lateral radiograph. This creates an upside-down V shape with the intersection of the right bronchus, looks like a man walking. Left atrial enlargement. 371. Left ventricle, the leaflets of the mitral valve are connected to the papillary muscles via cord-like tendons called chordae tendinae. The papillary muscles insert into the lateral and posterior walls as well as the apex of the left ventricle, not the septum, as is the case on the right. Echogenic focus in left ventricle, relatively common sonographic observation seen on prenatal ultrasound. It is a calcified papillary muscle that usually goes away by the 3rd trimester. So who gives a shit? Well, they are associated with an increased incidence of Downs, 13%. Don't get it twisted, having one means nothing other than you should look for other signs of Downs, most of the time it's normal. Echogenic focus in left ventricle. Lipomatous hypertrophy of the intra-atrial septum, this has a very classic look of a dumbbell, bilobed, appearance of fat density in the atrial septum, sparing the fossa ovale. It spares the fossa ovalis, creating a dumbbell appearance. When it doesn't spare it, think lipoma. It's associated with being fat and old. As a point of trivia, it can cause supraventricular arrhythmia, although usually does nothing. Additional even more high-yield trivia is that it can be hot on PET because it's often made of brown fat. 372. Sec 110N2 coronaris. Questions regarding the coronaris will likely come in two flavors, normal, which will be mostly vocab, and abnormal, which will only have one or two pathologies. Normal, there are three coronary cusps, right, left, and non-coronary, posterior. The left main comes off the left cusp, the right main comes off the right cusp. Left main. Right main. /circumflex, LCX, LAD. Acute marginal AV node branch. Obtuse marginals supply the lateral margin. Septal branches. Diagonals Ladford. Posterior descending artery, PDA, 65% to 80%, asterisk the other 20% have the PDA supplied by the left coronary. With regard to what perfuses what, the following are high-yield factoids. RCA perfuses SAN node 60%, RCA perfuses AV node 90%. 373. Typical vascular perfusion territories are a high-yield topic. 3-chamber long axis, 2-chamber long axis, mid-ventricle short axis. 2 vs 3-chamber view. These cardiac MR views are based off of the standard views they use in echo. The 2-chamber. This displays the LV and LA, 2 chambers. This is good for a few things. 1. Wattle motion I global LV function, and 2. Mitra. Valve issues, regurg etc. The anatomy trick would be to have you ID the coronary sinus on this view. The 3-chamber. Some people will call this an apical long axis view. The major plus to this view is that it lets you see the left ventricle far outflow tract, LVO, and is ideal for look at flow through this area, i.e. aortic regurg. A way a question could be asked is what view is best for aortic regurg? Stenosis, or which of the following views, and make you pick out the picture of the 3-chamber. Or just straight ask you, what is this view? RV. 4-chamber long axis. LVO. Coronary sinus. Dominance. Coronary dominance is determined by what vessel gives rise to the posterior descending artery and posterior left ventricular branches, most are right 85%. You can be codominant if the posterior descending artery arises from the right coronary artery and the posterior left ventricular branches arise from the left circumflex coronary artery. 374. Not normal, anomalies of the origin, course, and termination. Malignant origin, most common and most serious, LCA from the right coronary sinus, coursing between the aorta and pulmonary artery. This guy can get compressed and cause sudden cardiac death. Anomalous right off the left cusp - repair if symptomatic. Anomalous left off the right cusp always repair. Normal anatomy. RCA. Intraarterial LCA, the bad one. Alcapa, anomalous left coronary from the pulmonary artery. There are two types, A, infantile type, they die early, and B, adult, still at risk of sudden death. The multiple choice question is going to be Steele syndrome, which describes a reversal of flow in the LCA as pressure decreases in the pulmonary circulation. Myocardial bridging, this is an intramyocardial course of a coronary artery, usually the LAD. The finding may cause symptoms as the diameter decreases with systole, or may cause an issue for CAP planning. This can be a source of ischemia. Coronary artery aneurysm, by definition this is a vessel with a diameter greater than L.5x the normal lumen. Most common cause is atherosclerosis. Most common cause in children is Kawasaki, spontaneously resolves in 50%. They can occur from lots of other vasculitids as well. Last important cause is iatrogenic, cardiac cath. Coronary fistula, defined as a connection between a coronary artery and cardiac chamber or great vessels. It's usually the RCA, with drainage into the right cardiac chambers. They are associated I result in coronary aneurysm. If you see big crazy dilation of the coronaris, think about this. 375. Coronary CT. Who is the ideal patient to get a coronary CT? There are two main groups of people getting these. L. Low risk or atypical chest pain patients. A negative coronary CT will help stop a stress test or cath from occurring. Why do a procedure with risks on someone with GERD? 2. Suspected aberrant coronary anatomy. What is the ideal LIAT rate? To reduce motion-related artifacts a slow heart rate is preferred. Most books will tell you under 60 beats per min. Beta blockers are used to lower the heart rate to achieve this ideal rate. Are there contraindications 11s to beta blockers? Yup. Patients with severe asthma, heart block, acute chest pain, or recent snorting of cocaine should not be given a beta blocker. Are all heart blocks contraindications to beta blockers? Second and third degree are contraindications. A first degree block is not. What if I can't give the beta blocker? Can he still have the scan? Yes, you just can't use a prospective gating technique. You'll have to use retrospective gating. What is the difference between prospective and retrospective gating? Pro.backslash-pective, time step and shoot, our interval asterisk data acquisition triggered by our wave pro. There is reduced radiation B/C. The scanner isn't on the whole time con, no functional imaging trivia, always axial, not helical. Retrospective, scans the whole time, then back calculates pro, can do functional imaging con, high radiation, use of low pitch increases dose, trivia. This is helical other than beta blockers. Are any other drugs given for coronary CT? Yup. Nitroglycerin is given to dilate the coronaries, so you can see them better. Are there contraindications to nitroglycer-11E? Yup. Hypertension, SBP. 376. Section 3 valves. Velocity-encoded cine-Mr imaging, VENC, also known as velocity mapping or phase contrast imaging, is a technique for quantifying the velocity of flowing blood. Aortic stenosis, this may be congenital, bicuspid, or acquired, degenerative or rheumatic heart. Increased afterload can lead to concentric LV hypertrophy. Peak velocity through the valve can be used to grade the severity. Velocity-encoded cine-Mr imaging, VENC, which also answers to the name velocity mapping or phase contrast imaging, is an MRL technique for quantifying the velocity of flowing blood, if anyone would happen to ask. Dilation of ascending aorta is due to jet phenomenon related to a stenotic valve. Comes in 3 flavors, A, valvular, B, subvalvular, C, and supravalvular. Valvular is the most common, 90%. When I say supravalvular aortic stenosis you say Williams syndrome. Leon I say bicuspid aortic valve and coarctation you say Turner's syndrome. Bicuspid aortic valve, this is very common, some sources will say nearly 2% of the general population. As a result, it becomes the source of significant fuckery with regard to one particular multiple choice question, what is the most common congenital heart disease? The answer is probably bicuspid aortic valve, but because it's often asymptomatic and not a problem till later in life when it gets stenotic and causes syncope, I think it messes with people's math or doesn't get thought of by the question writer. How do you handle this question? Well, if they list bicuspid aortic valve then you have to pick it. If they don't list it then the answer is VSD. Trivia to know. Bicuspid aortic valve, even in absence of stenosis, is independent risk factor for aortic aneurysm. Association with cystic medial necrosis, CMN. Association with Turner's syndrome, and coarctation. Association with polycystic kidney disease. Aortic regurgitation, seen with bicuspid aortic valves, bacterial endocarditis, Marfan's, aortic root dilation from HTN, and aortic dissection. How rapid the regurgitation onsets determines the hemodynamic impact. Acute onset doesn't allow for adaptation. Mitra, stenosis, rheumatic heart disease is the most common cause. The case could be shown as ACXR with left atrial enlargement, double density sign, splaying of the carina, posterior esophageal displacement. 377. Mitral regurgitation. The most common acute causes are endocarditis or papillary muscle caudal rupture post-ME. Step 1 question was Austin Flint murmur. The chronic causes can be primary, myxomatous degeneration, or secondary, dilated cardiomyopathy leading to mitral annular dilation. Remember the isolated right upper lobe pulmonary edema is associated with mitral regurgitation. Pulmonary stenosis, just like in the aortic valve, comes in 3 flavors, A, valvular, B, subvalvular, C, and supravalvular. Valvular is the most common, and can lead to ventricular hypertrophy. Associated with Noonan syndrome, male version of Turner's. Peripheral pulmonary stenosis is seen with Alagille syndrome, kids with absent bile ducts. Williams can give you supravalvular aortic stenosis, and pulmonic. I. Williams syndrome. Noonan syndrome, Supravalvular stenosis. Valvular stenosis. Regurgitation, the most common situation for this is congenital valve disease after valve surgery. The classic scenario is actually TOF patient who has been repaired. Tricuspid regurgitation, most common form of tricuspid disease, due to the relatively weak annulus, compared to the mitral. May occur in the setting of endocarditis, for drug use, or carcinoid syndrome. Serotonin degrades the valve. The most common cause in adults is pulmonary arterial hypertension. A testable pearl is that TR causes RV dilation, not RV hypertrophy. Subvalvular stenosis. Pulmonary stenosis syndromes. Gamesmanship, rheumatic heart disease most commonly involves the mitral and aortic valves. Anytime there is multivalve disease, think rheumatic fever. Step I trivia: rheumatic heart disease is a immune-modulated response to group A beta hemolytic strep. Epstein anomaly, seen in children whose moms used lithium, most cases are actually sporadic. The tricuspid valve is hyperplastic and the posterior leaf is displaced apically, downward. The result is enlarged RA, decreased RV, atrialized, and tricuspid regurgitation. They have the massive box-shaped heart on CXR. Tricuspid ataxia, congenital anomaly that occurs with RV hypoplasia. Almost always has an ASD or PFO. Recognized association with asplenia. Can have a right arch, although you should think truncus and TOF first. As a point of confusing trivia, tricuspid ataxia usually has pulmonary stenosis and therefore will have decreased vascularity. If no PS is present, there will be increased vascularity. Carcinoid syndrome, this can result in valvular disease, but only after the tumor has met D to the liver. The serotonin actually degrades heart valves, typically both the tricuspid and pulmonic valves. Left-sided valvular disease is super rare since the lungs degrade the vasoactive substances. When you see left-sided disease you should think of two scenarios: 1. Primary bronchial carcinoid, or 2. Right-to-left shunts. 378. Sec 110N4 great vessels. The most common variant in branching is the bovine arch, in which the brachiocephalic artery and left common carotid artery arise from a common origin. The terminology right arch left arch is described based on the aortic arch's relationship to the trachea. When I say right arch with mirror branching, you say congenital heart. Bovine arch, or bovisal per Snoop Dogg. Left arch, normal, right arch. There are 5 types of right arches, but only 2 are worth knowing: aberrant left, and mirror branching. The trick to tell these 2 apart is to look for the origin of the left subclavian. Originating from the front of the arch equals mirror image. Asterisk, this is the bad one, L.Ots of congenital heart. Originating from the back of the arch equals aberrant left subclavian. 379. Right arch with aberrant left subclavian, the last branch is the left aberrant subclavian artery. This is a vascular ring because the ligamentum arteriosum, on the left, completes the ring encircling the trachea. Right arch with mirror branching, although these are often asymptomatic, they are strongly associated with congenital heart disease. Most commonly they are associated with TOF. However, they are most closely associated with truncus. Obviously, this tricky wording lends itself nicely to a trick question. If there is a mirror image right arch, then 90% will have TOF, 6% trunk 1. If the person has truncus, then they have a mirror image right arch 33%, I of 25%. Left arch aberrant right subclavian, the most common arch anomaly. Although it is usually asymptomatic, it can sometimes be associated with dysphagia luceraria, as the RSCA passes posterior to the esophagus. The last branch is the right aberrant subclavian artery. The origin of the RSCA may be dilated equals diverticulum of Comrill. Double aortic arch, the most common vascular ring. As a point of trivia, symptoms may begin at birth and include trickle compression and / or difficulty swallowing. The right arch is larger and higher, and the left arch is smaller and lower. Arches are posterior to the esophagus and anterior to the trachea, encircling them both. 380. Subclavian steal syndrome / phenomenon, so there is a syndrome and there is a phenomenon. The distinction between the two makes for an excellent distractor. SS phenomenon, stenosis and / or occlusion of the proximal subclavian with retrograde flow in the ipsilateral vertebral artery. SS syndrome, stenosis and / or occlusion of the proximal subclavian artery with retrograde flow in the ipsilateral vertebral artery and associated cerebral ischemic symptoms. LVERT. RSCA occlusion proximal to the vertebral in the subclavian can result in retrograde stolen flow from the vertebral artery. If the level of stenosis and / or occlusion is proximal to the vertebral artery, reversal of flow in the vertebral artery can occur, resulting in the theft of blood from the posterior circulation. When the upper limb is exercised, blood is diverted away from the brain to the arm. Cerebral symptoms, dizziness, syncope, etc., depend on the integrity of collateral intracranial flow, PCOMs. Subclavian steal is almost always caused by atherosclerosis, 98%, but other very testable causes include Takaysu arteritis, radiation, productive aortic coarctation, and Blalock-Taussig shunt. In an adult they will show atherosclerosis. If they show a teenager 20-year-old, it's gonna be Takaysu. Casebooks love to show this as an angiogram, and I think that's the most likely way the test will show it. They could also show ACTA or MRA, although I'd say that is less likely. Aortic aneurysm and vasculitis will be discussed in the vascular chapter. 381. Section 5. 0 genital heart. An extremely high-yield and confusing topic which dinosaur radiologists love to ask questions about on CXR. Obviously, this is stupid since you could only add confusion to a bad situation by suggesting a diagnosis on CXR instead of waiting for echo or MI. Having said that, the next section will attempt to provide a methodology for single answers on CXR cases. My thoughts on multiple choice questions regarding congenital heart is that they will come in 3 flavors: A, and mini, B, differentials with crappy distractors, and C, associations I trivia. And minis I differentials. There are a few congenital heart cases that are and minis, or easily solvable, most are differential cases. Bottom line is that if they want a single answer they will have to show you either an and mini or a differential case, with crappy distractors. With regard to straight-up and minis, I think the usual characters that most third-year medical students memorize are fair game. Scimitar sword, PAP with hypoplasia. 382. The easily solvable ones will be shown as a right arch with the associations of truncus, more closely associated, and TOF, more common overall. Or, they will show you the big box heart and want Epstein's, which is an and mini. Another classic trick with regard to the big box heart is non-cardiac causes of high output failure, infantile hemangioendothelioma and vein of Galen malformation. The remaining cyanotic syndromes basically look the same, so the questions must be either A, crappy distractors, none of the others are cyanotic, etc., or B, trivia, which is more likely. I cyanotic I. Asterisk they have to tell you this, if they want a single answer. Not cyanotic. 1. What side is the arch on? Left. I. Massive _ 2. Heart size. Ill. 3. Pulmonary blood flow. TAPF, especially type 3, TOFD transposition Ebst-Sins. 111J11 right TOF or truncus. Truncus TOF types 1 to 3. Epstein's or pulmonary ataxia without VSD non-cardiac, won't be cyanotic, infantile hemangioendothelioma vein of Galen malformation. Truncus, look for arch, tricuspid ataxia tingle ventricle. With regard to identifying bad distractors, think the easiest way is the cyanotic vs not cyanotic disorders. They literally must tell you the kid is cyanotic, otherwise there is no way to know. TLT cyanotic. FTC5FASO TAP VSD transposition POA truncus PAP tricuspid ataxia aortic coarctation, adult type, postductal. There are a few other key differentials that may make it easier to weed out bad distractors, or get which of the following do not questions. 383. CHF in newborn. TAPV, ultracardiac type ill. Survival dependent on admixture, POA, VSD, PDA, cyanotics TAPV, has PFO. Congenital aortic or mitral transposition stenosis T left-sided hyperplastic heart TOF, has VSD. D. Infantile, preductal, poplastic left coarctation. Small heart DDX. Adrenal insufficiency, Adelson's, cachectic state. Constrictive pericarditis car triatriatum cuspid. ____. Ataxia, has. Trivia and associations. VSD, the most common congenital heart disease. There are several types with membranous, just below the aortic valve, being the most common, 70%. Outlet subtypes, infundibulum, must be repaired as the right coronary cusp prolapses into the defect. On CXR we are very specific, big heart increased vasculature, small aortic knob. They could ask or try and show splaying of the carina, from big left atrium. About 70% of the small ones close spontaneously. PDA. The PDA normally closes around 24 hours after birth, functionally, and anatomically around 1 month. A PDA should make you say 3 things: 1. Prematurity, 2. Maternal rubella, 3. Cyanotic heart disease. CXR is specific, big heart, increased pulmonary vasculature, large aortic arch ductus bump. You can close it or keep it open with meds. ASD, several types with the secundum being the most common, 50 to 70%. The larger subtype is the primum, results from an endocardial cushion defect, is more likely to be symptomatic. Only secundums may close without treatment, primum, AV canal, sinus venosus will not. Primums are not amendable to device closure because of proximity to AV valve tissue. On CXR if it's small it will show nothing, if it's large it will be supinaspecific, big heart, increased vasculature, and small aortic knob. It's more common in female. When I say hand /thumb defects and ASD, you say Holt Oram. When I say ostium primum ASD, or endocardial cushion defect, you say Downs. When I say sinus venosus ASD, you say PAPV. 384. AV canal, also referred to as an endocardial cushion defect. They happen secondary to a deficient development of a portion of the atrial septum, a portion of the interventricular septum, and the AV valves. Strong association with Downs. You can't use closure devices on these dudes either. Surgical approach and management is complex and beyond the scope of this text. Trivia: of all the congenital heart stuff with Downs patients, AV canal is the most common. Eroofed coronary sinus. This is a rare ASD which occurs secondary to a fenestrated, as in the cartoon, or totally unroofed coronary sinus. The most important clinical is that you can get paradoxical emboli and chronic right heart volume overload. Trivia: strong association with a persistent left SVC. PAPV, partial anomalous pulmonary venous return, is defined as one, or more, of the four pulmonary veins draining into the right atrium. It is often of mild or no physiologic consequence. It is often associated with ASDs, secundum and sinus venosus types. When I say right-sided PAPV, you say sinus venosus ASD. ORUL, SVC association with sinus venosus type ASD. When I say right-sided PAPV plus pulmonary hypoplasia, you say scimitar syndrome. Sinus venosus ASD. 385. TAPV, a cyanotic heart disease characterized by all of the pulmonary venous system draining to the right side of the heart. A large PFO or less commonly ASD is required for survival. This is a high yield and testable point. There are 3 types, but only 2 are likely to be tested. Cardiac type 2 just doesn't have good testable features. All 3 types will cause increased pulmonary vasculature, but type 3 is famous for a full-on pulmonary edema look in the newborn. Type 1, supracardiac. Most common type O veins drain above the heart, gives a snowman appearance. Type 2, cardiac O. Second most common type 3, infracardiac O veins drain below the diaphragm, hepatic veins or IVC, O obstruction on the way back through diaphragm is common and causes a full-on pulmonary edema look. Key points on TAPV. Supracardiac type equals snowman, infracardiac type equals pulmonary edema in newborn large PFO, or ASD, needed to survive asplenia. 50% of asplenia patients have congenital heart issues, of those nearly 100% include TAPV, 85% have additional endocardial cushion defects. 386. Transposition. This is the most common cause of cyanosis during the first 24 hours. It is seen most commonly in infants of diabetic mothers. The basic idea is that aorta arises from the right ventricle and the pulmonary trunk from the left ventricle, ventricular-arterial discordance. Which one is the right ventricle? You have to find the moderator band, that defines the RV. Just like TAPV, survival depends of an ASD, VSD, or PDA, most commonly VSD. There are 2 flavors, D and L. The D type only has a PDA connecting the 2 systems, whereas the L type is lucky enough to be compatible with life. Detransposition, classic radiographic appearance is the egg on a string. Occurs from discordance between the ventricles and the vessels. The intra-atrial baffle, mustard or Senning procedure, is performed to fix them. L transposition, the L type is lucky enough to be congenitally corrected. This occurs from a double discordance where the atrium hooks up with the wrong ventricle and the ventricle hooks up with the wrong vessels. In zero transposition, the ductus may be the only connection between the 2 systems, which would otherwise be separate, and not compatible with life. In L transposition of the great vessels, there is an inversion of the ventricles, leading to a congenital correction. No PDA is needed. A corrected D transposition has a very characteristic appearance, lending itself to an Aunt Minnie type question. The par is draped over top the aorta, which occurs after a surgeon has performed to look and maneuver. Sounds French, so must be high yield. 387. Tetralogy of Fallot, TOF, the most common cyanotic heart disease. Describes 4 major findings: 1. VSD, 2. AV obstruction often from valvular obstruction, 3. Overriding aorta, 4. RV hypertrophy, develops after birth. The degree of severity in symptoms is related to how bad the AV obstruction is. If it's mild, you might even have a pink tet that presents in early adulthood. This is called a pentalogy of Fallot if there is an ASD. Very likely to have a right arch. Surgically it's usually fixed with primary repair. The various shunt procedures, Blalock-Torsig being the most famous, is only done if the kid is inoperable or to bridge until primary repair. Trivia: the most common complication following surgery is pulmonary regurgitation. Truncus arteriosus, cyanotic anomaly where there is a single trunk supplying both the pulmonary and systemic circulation, not of a separate aorta and a pulmonary trunk. It almost always has a VSD, and is closely associated with right arch. Associated with catch-22 genetics, D.I. George syndrome. Coarctation, narrowing of the aortic lumen. This comes in 2 flavors: 1, infantile, preductal, These guys can have pulmonary edema, too. Adult, ductal, things to know. Strong association with Turner's syndrome, 15 to 20%. Bicuspid aortic valve is the most common associated defect, 80%. They have more berry aneurysms. Figure 3 sign, appearance of CXR. Rib notching, most often involves 4th, 81H ribs. It does not involve the ST and second because those are fed by the costocervical trunk. Hyperplastic left heart, left ventricle and aorta are hyperplastic. They present with pulmonary edema. Must have an ASD or large PFO. They also typically have a large PDA to put blood in their arch. Strongly associated with aortic coarctation and endocardial fibrolastosis. 388. Cor triatriatum sinistrum. This is a very rare situation where you have an abnormal pulmonary vein draining into the left atrium, sinistrum meaning left, with an unnecessary fibromuscular membrane that causes a subdivision of the left atrium. This creates the appearance of a triatrium heart. This can be a cause of unexplained pulmonary hypertension in the PED setting. Basically it acts like mitral stenosis, and can cause pulmonary edema. The outcomes are often bad, fatal within 2 years, depending on surgical intervention and associated badness. Cor triatriatum sinistrum. 389. Section 6. Ischemic heart. Imaging regarding ischemic heart disease is going to fall into 2 modalities, cardiac MR, and nuclear. Cardiac MI currently offers the most complete evaluation of ischemic heart disease. Myocardial infarction typically is initiated by rupture of an unstable coronary atherosclerotic plaque, leading to abrupt arterial occlusion. The wavefront of necrosis always starts subendocardial and progresses to the subpicardium. The ischemic necrosis will affect not just the myocardium but also blood vessels. The destruction of small capillaries will not allow contrast to the area of injury. THIS is termed microvascular obstruction and manifests as islands of dark signal in a notion of delayed enhancement. The presence of microvascular obstruction is an independent predictor of death and adverse LV remodeling. Testable vocab. Stunned myocardium, after an acute injury, ischemia or reperfusion injury, dysfunction of myocardium persists even after restoration of blood flow, can last days to weeks. A perfusion study will be normal, but the contractility is crap. Hibernating myocardium, this is a more chronic process, and the result of severe CAD causing chronic hypoperfusion. You will have areas of decreased perfusion and decreased contractility even when resting. Don't get it twisted, this is not an infarct. On AFDG PET, this tissue will take up tracer more intensely than normal myocardium, and will also demonstrate redistribution of thallium. This is reversible with revascularization. SCA, this is dead myocardium. It will not squeeze normally, so you'll have abnormal wall motion. It's not a zombie. It will not come back to life with revascularization. Stunned hibernating J infarct SCA. Wall motion abnormal abnorm 1 L _ normal perfusion, thallium abnormal fixed perfusion J abnormal fixed perfusion or systemic B. Will redistribute with will not redistribute with delayed thallium and will delayed thallium, will not. Take up FDG. Associated with acute ME associated with chronic high associated the chronic prior grade CAD ML. 390. Delayed imaging, it works for 2 reasons. 1. Increased volume of contrast material distribution in acute myocardial infarction and inflammatory conditions. 2. Scarred myocardium washes out more slowly. It is done using an inversion recovery technique to null normal myocardium, followed by a gradient echo. TL shortening from the GD looks bright is dead. Why stress imaging is done? Because coronary arteries can autoregulate. A stenosis of 85% can be asymptomatic in a resting state. So demand is increased, by exercise or drugs, making a 45% stenosis significant. An inotropic stress agent, dobutamine, is used for wall motion, and a vasodilator, adenosine, is used for perfusion analysis. MI in acute ME, cardiac MI can be done in the first 24 hours post-ME, if the patient is stable. Late gadolinium enhancement will reflect size and distribution of necrosis. Characteristic pattern is a zone of enhancement that extends from the subendocardium toward the epicardium in a vascular distribution. Microvascular obstruction will present as islands of dark signal in the enhanced tissue, as described above, and this represents an acute and subacute finding. Microvascular obstruction is not seen in chronic disease as these areas will all come to scar eventually. In the acute setting, 1 week, injured myocardium will have increased T2 signal, which can be used to estimate the area at risk. T2 BRI, enhanced equals salvageable tissue. Acute vs chronic ME. Both have delayed enhancement. If the infarct was transmural and chronic, you may have thinned myocardium. Acute will have normal thickness, chronic can too but shouldn't for the purposes of MC tests. T2 signal from edema may be increased in the acute setting. You won't see microvascular obstruction in chronic. Acute is T2 bright, edema, chronic is T2 dark, scar. Low do you diagnose myocardial LLF, 1 with contrast enhanced Mr. I. Delayed enhancement follows a vascular distribution. 2. The enhancement extends from the condycardium to the epicardioum. 391. Microvascular obstruction, islands of dark tissue in an ocean of late GD enhancement. These indicate microvascular obliteration in the setting of an acute infarct. The GD is unable to get to these regions even after the restoration of epicardial blood flow. Microvascular obstruction is a poor prognostic finding, associated with lack of functional recovery. Key point, it's not seen in chronic infarct. Trivia, microvascular obstruction is best seen on FRST pass imaging, 25 seconds. Ventricular aneurysm, this is rare, 5%, but can occur as the result of ME. The question is always true vs false. True, mouth is wider than body. Myocardium is intact. Usually anterior lateral wall. False, mouth is narrow compared to body. Myocardium is not intact, pericardia. Adhesions contain the rupture. Usually posterior lateral wall. High risk of rupture. False aneurysms are usually posterior lateral, true aneurysms are usually anterior lateral. Viability, you can grade this based on % of transmural thickness involved in the infarct. 25 to 50%, may improve. 50 to 100%, unlikely to recover function. What is the timing on the bad sequelae of and me? I Dressler syndrome 4 to 6 weeks I. U, LR_U_Ch_2 to 7 days. _JI ventricle pseudoaneurysm 3 to 7 days T ventricular aneurysm months, requires remodeling and thinning. Myocardia rupture _J, 50% of the time, _J. 392. Section 7. Non-ischemic heart. Dilated cardiomyopathy, defined as dilatation with an end diastolic diameter greater than 55 mm, with a decreased F. Can be idiopathic, ischemic, or from a whole list of other random crap, alcohol, doxorubicin, cyclosporine, shigas, etc. The ischemic variety may show subendocardial enhancement. The idiopathic variety will show either no enhancement or linear mid-myocardial enhancement. There is often an association with mitral regurgitation due to dilation of the mitral ring. Restrictive cardiomyopathy, basically anything that causes a decrease in diastolic function. Can be the result of myocardium replaced by fibrotic tissue, endocardial fibroblastosis, infiltration of the myocardium, amyloidosis, or damage by iron, hemochromatosis. The most common cause is actually amyloid. Restrictive equals myocardial process, constrictive equals pericardia. Amyloidosis, deposits in the myocardium causes abnormal diastolic function with biatrial enlargement, concentric thickening of the left ventricle and reduced systolic function of usually both ventricles. Seen in 50% of cases of systemic amyloid. Has a terrible prognosis. You can sometimes see late GD enhancement over the entire subendocardial circumference. Amyloid classic scenario, a long T is needed, like 350 ml.